present on high tibial osteotomy. We have done a meta-analysis review article, which is a meta-analysis was high tibial osteotomy and the radiological outcomes in that study. So all we know, every time we are so much confused about what are the cases, what are the everything. There are various cases like medial joint.
Can you hear me?
Yeah.
Your voice is echoing a little,
Yes, sir.
so if you may just.
Yes, I'll try, sir. Is it fine, sir?
Yeah, it's a little better, though it's echoing still, but we are better.
Can I continue, sir?
Yeah,
Yeah, please.
Talk a bit louder. Yeah.
All right, sir. So there are various osteoarthritis which we come across. There's a lateral compartment osteoarthritis and medial compartment osteoarthritis. A large number of treatment options available, like a unicondylar knee, braces, open wedge osteotomies, lateral wedge osteotomies, as well as the current trend emerging is proximal femoral osteotomies and also distal femoral osteotomies. We have a great variety of implants to be used in all this, like staples, tomofix, peak plates, and other various. So the article which we are going to review is generally it's done by Dr. Ling Fu and Dr.
Mihir, can you
Jing
be
Lee, and
louder? Your
they
voice is
both belong to they both belong to the China universities. All right, these are the places where they belong from. All right, article which we have done basically is about the high tibial osteotomy. All right, it's open versus closed osteotomy clinical outcome and as well as the article also consisted all the articles which were PubMed, Scopes, Embase, and ISS Web Knowledge and Consciousness Library. The outcomes included in the search were uh, osteotomy, tibial, closed or closing wedge, and open. All the studies published before 2016 in English were considered in this meta-analysis. There were completely 530 studies were referred after applying protocols for the meta-analysis. Only 22 were considered, out of which 7 were random control trials and 15 were non-random control trials. There were a total of 2,582 cases, out of which 1,274 were open wedge and 1,308 were closed wedge. The meta-analysis used a fixed effective modules. If there was no significant heterogeneity, a random effect was applied. To assess the heterogeneity between the studies, a chi-square test was estimated. For all the p-values less than 0.05 were considered statistically significant. All the articles reviewed in this meta-analysis, they were assessed based on revised JD scale of Conchere's non-randomized study methods working group. That means that with a score of 4 to 7, if a study had a score of 4 to 7, they were good studies and were included in this meta-analysis. If the score was 0 to 3, they were considered poor and were discarded from this analysis. The clinical outcomes were compared with surgical time, duration of hospital stay, HSS knee score for 1 year follow-up, knee pain VAS score, range of motion, and lysosome knee score was considered. While doing this meta-analysis, there was no significant differences in the surgical time and duration of hospital stay, as indicated by random effect model. There was no significant difference regarding the knee pain VAS score and lysosome score using the fixed effect model. The lysosome score consists of total 100, which is always assessed pre-operative and post-operative, which consists of different parameters like stiffness, climbing, swelling, pain, limp, and they are given accordingly, the scores are given. This is done at 1 month, 3 months, and 6 months, and so on. They also find a slightly but not significant higher hospital for special surgery knee score, which has a total score of 50, depending upon the pain, limb, and range of motion. That was observed that the menial osteotomy had a higher score, but that was not significant as compared to the closed wedge osteotomy. Interestingly, significant difference was observed regarding the increased range of motion, that is the flexion angle post-operatively between the open wedge and the closed wedge groups. On radiology, high knee angle, hip knee angle, and mean angle of correction had no significance. There was no difference between the closed wedge group and the open wedge group. But on the posterior tibial slope, there was a significantly greater posterior tibial slope angle in open wedge osteotomy. The patellar height, which was calculated using the Canton's index and Insal Salvati index, they found out that there was higher, greater patellar height in closed wedge compared by Anton's index and incel Salvati ratio, but by calculating by Blackburn Peel ratio, there was no significant difference between open wedge and the closed wedge. The downside of this complete study was all the opening wedge patients received the range of motion exercise post-operatively, which was not the case in closed wedge in the group of studies which were done. In the meta-analysis, two studies from the Song et al. Constitute the largest portion of the overall sample size, which might have led to the biased result regarding the range of motion. But there were different surgical approaches, small sample size, insufficient method of description, low reliability of radiographic results, and study design in these studies, which might have led to the heterogeneities between the two groups. In the conclusion of this paper, except for the range of motion, posterior tibial slope, and patellar height, there was no difference between the open wedge and the closed wedge. Both had satisfactory and comparable clinical and radiological outcomes. On the light of the above analysis, we believe that individualized surgical approach should be introduced based on the clinical characteristics of each patient. I thank you for your patience listening. Thank you very much.